I am taking the stance that there is no benefit for routine use of intraoperative neuromonitoring in degenerative lumbar spine surgery. No relevant disclosures. So the reasons that intraoperative neuromonitoring is utilized, kind of per the survey, sort of demonstrated this as medical legal, surgeon comfort training. Great talk, by the way, Mike, and some really good points that I agree with a lot of them. And the prevention of neurological injury are all reasons to utilize intraoperative neuromonitoring. Specifically, the prevention of neurological injury and deformity and tumor, when there are cases where we can adjust what we're doing for, for deformity correction and make adjustments to prevent neurological injury. But the goal of intraoperative neuromonitoring is to identify neural irritation and injury at the time when a surgeon can take steps to reduce or reverse it, or define the nature of an injury to proceed with the surgery safely. Those are the goals, right? There's no point in neuromonitoring just to identify that you've made an error, right? You want to be able to, if you've made an error intraoperatively, to go on and fix that error to reduce the amount of morbidity that the patient suffers. So, just because we have a goal doesn't mean we attain that goal. And I think there's a lot of debate between the ability to actually reduce a post-op neurological deficit when you are using intraoperative neuromonitoring, specifically for a lumbar degenerative case. And most of the time we talk about this, we're talking with pedicle screw insertion and medial breaches or inferior breaches of the pedicle screw. Certainly there's benefit in tumor and deformity surgery, but if you look at some of the best studies, there's very low evidence that neuromonitoring reduces the rate of neurological deficits or neurological injury. It can alert you to a neurological injury, but it doesn't mean that it changes it. So I'm going to go through just a few studies. In full disclosure, a lot of the studies on this, like Mike said, they're kind of all over the place, right? And the rate of a neurological injury with a degenerative lumbar case, such as a TLIF, is very, very low, right? So a lot of these studies with a couple hundred patients are significantly underpowered to really tell us anything with granular detail. But just to kind of go through a few, here's a study that looked at cost effectiveness and surgery time in patients undergoing intraoperative neuromonitoring for discectomy. And, of all the patients, 91 of them, none of them had a motor weakness. It's just demonstrated increased operative time and increased operative costs. And I don't know how many of us use neuromonitoring for discectomies. I tend not to, but I think that's probably most common. What about when we start putting in screws? So this is a study of 112 patients, most of them with neuromonitoring, but about 2/3 of them, or 1/3 of them without. And there was no difference in the length of stay. There was no difference in the need for revision surgery between the two groups. It just demonstrated increased costs and increased length of surgery with neuromonitoring. So as we get into some better studies as time has gone on, this is a systematic review of 32 articles. It kind of speaks to, yes, you can pick up a neurological injury if you neuromonitor. You can see if something's happened often, but it doesn't mean that it changes your final outcome. So I'm very interested to hear the last talk on some of the medical legal issues with it. But in my head, I think to myself, well, do I really want to say and document that I've caused a neurological injury that I can't fix, right? Is that a good thing from a medical legal standpoint? I know it feels good and it sounds good to say I neuromonitored, but I don't know when you get down to it, if you can't change it, if it's really what you want to document during surgery. So their recommendation in this article was to be used in cases where the spinal cord or roots are at risk, such as a deformity surgery. And certainly as a group of spine surgeons, we need to develop more evidence-based protocols when and how we should use intraoperative neuromonitoring. So in 2014, the AANS updated their guidelines for performing neuromonitoring in degenerative surgery. And this is the paper in the journal Neurosurgery Spine. And basically, if you get down to it, what they suggested in their guidelines is there's really no evidence that intraoperative neuromonitoring can prevent an injury to a nerve root. There's some evidence that a threshold below 5 milliamps with direct stimulation can indicate a medial pedicle breach. But even if you breach the pedicle or put a screw through a nerve root, inferior or medial, it doesn't mean that you could do anything to fix that after that's done. So it doesn't necessarily alter your outcome. So what are we talking about when we say neuromonitoring? Mike went through this really nicely, probably better than I'm going to, but So we tend to use triggered EMG. And what triggered EMG is we put the pedicle screw in, and then we stimulate the pedicle, and then there's a certain threshold, and we say if it's below that threshold, it's stimulating the nerve root relative to the control. That is a positive response. Traditionally, in the lumbar spine, that's less than 10. In the thoracic spine, that's less than 6. But again, there's some evidence that suggests that if you use 5 as your threshold, it's a little bit more sensitive to pick up sensitive and specific to pick up a neurological injury or medial pedicle breach. The problem with triggered EMGs is there's a lot that goes into getting a good reading that sometimes is difficult to do, right? So the anesthesia can be a problem, the use of muscle relaxants, any pre-existing nerve damage. So a lot of these patients, they have a problem with the nerves. That's why we're doing surgery in the first place, right? And so it can alter your reading, so you don't know if you're getting a good reading anyway. You got to make sure the field is clear of blood, and you're not trying to conduct through blood. And you want to stimulate the screw itself. You can't just put the probe on the tulip and say that's a reading. It's not really a good reading. So there's so much user error that can go into triggered EMG that it's very hard to know, am I getting a good reading? Is this helping? And in the cases, I in full disclosure, I use very, very little neuromonitoring in my own practice. And I could say when I do use neuromonitoring, it doesn't do anything but increase my stress level. I'm more stressed out when I use neuromonitoring than I am when I'm not. And I think some of the user errors and not knowing if I'm actually getting a good reading back is part of what contributes to that stress. Here's kind of an interesting article I did want to go through that actually, if you look at it on the surface, probably speaks to the other side. But this is a very recent article with a good number of patients, 4,400 patients. And what they looked at is, forget about the triggered EMGs. What if we look at MEPs? And so they demonstrated that they thought EMGs were not very sensitive, with only a 4.3% sensitivity, whereas an MEP, it was 100%. So what they did is they compared it against like the Tibant, and if somebody woke up with a foot drop, if the MEP dropped below 50% threshold, that was considered a positive response. So typically we've all learned as we study for our boards over the years that it's less than, if it drops more than 80%, that's a positive response in your motor evoked potential. They used 50% as a threshold. And of the ones that they couldn't fix, right? So if somebody had a positive change in their MEPs, or they lost MEPs in the nerve root in question, and it didn't change during surgery, all of them woke up with a deficit. So what that sort of tells me on the surface is that, yes, you can identify it and you could be sensitive, perhaps specific, but it doesn't necessarily mean that you could do anything to change it. And I think they demonstrated that pretty clearly. Now, they did have a cohort of patients, around 25 patients in this study, that they did do some things in surgery to change it, and they didn't wake up with deficits. So if they had a resolution of their decreased response, if their MEPs dropped and then they did some things in surgery, and then their MEPs came back, those patients woke up relatively normal or without a new neurologic or progressive neurologic deficit. But what's interesting is if you read the article, right, what did they do to change things? I mean, there's a couple of cases where they redirected a screw fine, but most of it was close a dural tear or release distraction when they're doing a TLIF, or stop, tugging on the nerve root. These are all things that we're going to do anyway. And I think that sort of speaks to the conclusions here, is that I don't think intraoperative neuromonitoring has a role for routinely being performed in degenerative lumbar spine surgery. And I don't know if it's a good thing from a medical legal standpoint to indicate that you caused an injury if you don't have the ability to change it. And I also think that I don't think it should be used as a crutch for poor technique, right? So if they need to do more decompression because they had a change in their MEPs, we should be doing our complete decompressions. We should be palpating the medial borders of the pedicles. We should be ball tip probing our screw tracks, to make sure all that's okay. After the screw's put in and decompression's done, you should be looking at the medial border of the pedicle to make sure there's no screw threads that are there. So I don't think neuromonitoring is good in the sense that it can be used as a crutch, and I don't think it should be used as a crutch, right? I think it shouldn't replace good technique. And I think the corollary there is the O-arm. I use the arm a lot, admittedly, not usually for degenerative cases, but it doesn't mean that I should always just believe what the screen is telling me when I'm using an arm, right? You got to look at your anatomical landmarks and make sure it makes sense where you're putting the pedicle screws in, because there's error in technology. And I think intraoperative neuromonitoring in routine use is the same thing. There's errors in using it routinely, and just relying on it, I think, is a dangerous thing. I think there's a lot of technical issues with triggered EMGs. MEPs are an interesting option, but the overall rate of injury with a standard degenerative lumbar case is so low. I think that I don't think we have a good answer for whether or not it changes things in spine surgery. And my personal opinion after reading literature is that I don't think routine use will change a rate of neurological injury, which is really what we care about. I do think there's some role for it. I think select cases, if somebody has really small pedicles and it's going to be a difficult surgery to do safely, and it's going to be hard to get in the canal and palpate the medial border of the pedicle, and et cetera, et cetera. There's certainly uses for intraoperative neuromonitoring. I'm not saying it should never be used, but I just don't think it should be used routinely.